Welcome back. I'm your host, Michael Stamatinos, with the Advancing Healthcare Innovation Show. And look, if you're new to us, we're just super excited to have you here. We also happen to be really passionate around healthcare innovation, adoption, leadership, access, and just in general, getting stuff done. And if this is your first time tuning in, let me just kind of tell you a little bit more about what we do here. So, we're a healthcare innovation company. We're focused on bringing stories of innovation within healthcare to life. And our aim is highlighting real people that are in our space and giving them the platform to be able to share their stories, successes, and setbacks with the world. And look, we've had an incredibly action-packed year so far. We also have some amazing content that's being planned for the new year. And if you haven't checked out any of our earlier interviews, please check them out. So I'm super excited about today's guest, Dr. Michael Hasselberg, who happens to be the Chief Digital Health Officer at University of Rochester Medical Center. Dr. Hasselberg, welcome to the show.
Thank you, Michael. I'm stoked to meet with you and talk with you today.
Yes. So I'm wondering if you wouldn't mind maybe just giving a little bit of background of your story, a snippet, because it's a fascinating story, into sort of your journey into how you became a chief digital health officer, because this is sort of a newer role. But if you wouldn't mind maybe just giving our audience a little bit of a taste of that story, that'd be great.
Yeah, sure, absolutely. Yeah, so my story, I think there's a lot of serendipity in it. First and foremost, I'm very proud. I'm a nurse, a psychiatric nurse who went on to become a nurse practitioner. I started my career as a psych MP in a very rural community in upstate New York, where, to be frank, I was the only psychiatric provider for like 4 counties around us. And if you needed a psychiatric med, like I was it. So that experience was really eye-opening for me in regards to disparities of healthcare in rural America. I ended up continuing my schooling. I received a Ph.D, a very research-focused Ph.D. I was a clinical trialist, and the population I was most passionate about, and I'm still very passionate about, was Alzheimer's disease. And my hope was that I was going to be that guy that helped find a cure for Alzheimer's disease. So I did, pharmacology, clinical trial research. Interestingly, I'm born and raised in Rochester, New York. I love my community, and the only real player in town where I could do good clinical trial research was at the University of Rochester Medical Center. And fortunately, and unfortunately, the chair of the Department of Psychiatry, who was recruiting me to join faculty, I think he saw promise in me as a clinician researcher, but he was not excited about my pharmacology research. And he said, listen, if I'm going to kind of put my neck out there and bring you as a nurse on to faculty in the School of Medicine, which I'm very proud of. Also, I'm the first and only nurse that has a faculty appointment in medicine. My secondary appointment's in nursing. I really want you to develop telemedicine for the Department of Psychiatry. And this was around 2009, 2010. And if anybody remembers, back 10 years ago, there really was no reimbursement for telemedicine. But I had a chair who understood that healthcare was growing in terms of geographic reach, understood that there was needs in these rural communities for behavioral health care, and wanted to spread access. So I said, all right, I knew nothing about technology. I said, I'm your guy. I'll take this on. And quickly started learning about telemedicine. I got lucky. I submitted several grants, which hit, and I started building a really large telemedicine program that was all grant funded, and ended up being statewide across pretty much all of the state of New York, with the exception of New York City and Long Island. And a very traditional telemedicine program. You know, we supported primary care practices in the state. We then moved from primary care practices to supporting rural community hospitals and the emergency departments and inpatient medical units, and then moved from there into serving nursing homes. I then became really anxious because I essentially was supporting a very large team of clinicians now who their livelihoods were dependent on me getting another grant to support their FTE because, again, you know, the reimbursement just wasn't there. So I decided, you know, I needed to really understand how finances worked in healthcare, and this was right around the time that the ACA was being rolled out, and I really needed to understand, what did it mean, this discussion about moving from volume to value? Like, what did that truly mean? So I ended up going back to school again, and I got this kind of crash course certificate and, you know, healthcare finance and leadership, which was game changing for me. So I came back to Rochester. I started looking at my telemedicine programs through the lens of a payer. And interestingly, the outcomes that the payers were interested in were not the outcomes that me as a clinician researcher were interested in. And so when I started thinking through the lens of a payer, I was able to successfully negotiate early value-based reimbursement contracts with our local commercial insurers and the state Medicaid plan to essentially sustain those telemedicine models that I had built in the state. And again, this was well before telemedicine was cool during the COVID pandemic. Right. I then ran into another issue. I figured out regs, I figured out payments for telemedicine, but I couldn't take on more patients on the spoke end because I couldn't graduate psychiatrists fast enough to take on more patients. So I then kind of moved into the innovation world. This was about 7 years ago. The Department of Orthopedics at the medical center was starting an innovation arm. You know, orthopedics and fee for service is a wealthy department. They could afford investing into innovation. I got connected to this hand surgeon who's also an engineer, who was leading this innovation team, and we just really hit it off. So we got a flight of ideas. I started writing grants to partner with our engineering school to build cognitive behavioral therapy mobile app. I started getting into the VR, AR space and started building applications in that space. I started to learn to code a little bit, and then kind of moved from apps to chatbots, and then from chatbots, I moved into machine learning and data science. Throughout this time, I got lucky, and I was selected to become a fellow of the Robert Wood Johnson Foundation, which really opened up really great network to me, to other innovators on the other side of the country, on the West Coast, at Stanford University and Providence Health System out of Seattle, and got to start to meet a lot of startup companies and a VC fund. So really started to understand more about frontier technologies. And then in March of 2020, the world changed. COVID hit, and I was tapped on the shoulder by our CEO to essentially convene a team to stand up telemedicine for the whole health system in like a week. We did that. 6 months in, we realized, hey,
well, I feel like you had the foundation. You had the foundation at that point, you know?
Yeah, we had a great foundation. So it was really easy for us to flip that switch on for the whole health system, where we went from like having 2% of our ambulatory volumes being provided by telemedicine pre-pandemic to like over 80% in like a few days, which was great. But 6 months in, we realized the pandemic wasn't going away. We needed more digital solutions to support our teams and our staff, but we had no strategy, no digital transformation strategy. So we were spreading all of our IT resources very thin because we were having trouble prioritizing what to focus on. And the CEO then tapped me on the shoulder and asked if I would take my current role of chief digital health officer to essentially develop and set that digital transformation strategy for the health system. So really now, I've got this I think the best job in the world. I part of my time is really high level strategy around digital transformation for the university's health system, and then the other half of my time is really co-leading now the innovation incubator with Dr. Dave Mitten, that hand surgeon I told you about, where we get to develop new technologies on kind of the frontier end and get to partner with startup companies and bring those technologies into our health system.
So a lot that you just said there. But let me just kind of unravel that because my mind is internally spinning. First things first, it sounds like you're a lifelong learner. You have a curious mind, a childlike curious mind, which is an amazing thing. You want to learn and continue to get better and apply. And it kind of goes to show with what you shared. I'm curious, on a scale of 1 to 10, how lucky do you think you are? One
Oh
being not so
gosh.
lucky, 10 being very lucky. Because you said
100,
lucky a few times.
115, lucky in a lot of ways, lucky in the sense
And
that,
what degree, to what degree do you think luck played in all of these opportunities that were placed in front of you?
you know, so, in innovation, you need to take risks, and you need to take strategic risks. And you also have to have a lot of luck, because we know in innovation, things fail and things fail fast. I'm a guy, I think, who's willing to take risks. I do take very thoughtful, strategic risks. But if it's like you said, if it's something I find interesting, or it sounds like a lot of fun, and the people that I'm going to be working with are also great people, I'm more likely to say, yeah, let's give it a try. Let's think about this and let's do it. And so there is a luck component, but when I think of luck, I really think I'm the luckiest person in the world. Like, I love what I do. I
Yeah.
love my team. I love my organization, and I love my community and the impact that we're making. And so, like, who can ask for anything more in life than to, have a job that you just love and you're passionate about? And that doesn't happen to a lot of individuals. So I find myself as
Yeah.
very lucky to have that.
It doesn't sound like it's a job. It sounds like it's more or less a calling for you. Like you're doing what you were designed to be doing, and that's pretty amazing. Talk a little bit about your team, scale, size of the team. Can you maybe comment around that?
Yeah, so on our innovation hub, we have about 30 faculty members that are part of the innovation team, which are also supported by maybe 5 to 8 staff members. One of the things that makes the University of Rochester Medical Center unique, Michael, is we're one of only a handful of academic health systems left in the country that is still integrated to its parent university. And so what that means is the health system's budget rolls up to the university's budget. Now, the downside of that is, a good portion of our margins on our health system goes over to the college to support the academic and research missions. Most health systems have learned, hey, if I break away from my parent university, it's easier for me to make my annual 1 to 2% margins per year if I'm not sending money over to the college. We've
Right.
made a conscious decision that we're not going to do that. We're not going to break away. And that's a differentiator for us. And where I say that is those 30 team members, faculty members that I have in our innovation incubator, they're across all of our colleges. So I have faculty members in the engineering school, in our computer science department, our data science institute, our business school. I even have faculty members from our music school that sit under the same roof as faculty members from the medical school, the dental school, and the nursing school. And so you have this kind of really diverse petri dish of knowledge. And we really get to really do fun things and use design thinking to come up with outside the box solutions to problems that our business, the health system, is struggling with. So it is really a unique entity with a really fun team. And people say, a music professor? Yeah, I have a professor of music theory that helps give guidance on digital solutions we develop. I have a medical ethicist that sits in our lab that makes sure that the AI we develop, doesn't have biases that may have negative impact after we develop these models. I mean, like, where else do you find a team like that?
It sounds like it's a superpower.
Yeah,
Is what it really is. It's a hidden superpower. You know what the amazing thing is, and I got this from our early conversation, is, you know, when people talk about innovation, they think of the big brands. And that's only like maybe 1% of innovation that really happens within healthcare. And to find a diamond, I really feel like we have acres of diamonds. I don't know if you ever read that book, but Russell Cronwell. But for those leadership junkies that are out there, they'll know what I'm talking about. But there's like acres of diamonds everywhere. And I think they can be in situations just as the one that you're in. They just don't happen to get highlighted. I'm curious, you mentioned something around risk and taking risk. Aside from having fun and being passionate around a problem, can you describe sort of maybe your matrix, your thought process on what does it mean to take a level of risk, and just kind of walk us through what that process looks like from your seat, thinking like a payer, thinking about the financial implications, and just give us a little bit more context around it, if you wouldn't mind.
Yeah, so a lot of where we are innovating and disrupting is in the service lines that typically don't make our health system money. And so when I say that, my health system, like 95% of the health systems across the United States, the we primarily get reimbursed through fee for service. And where digital health and innovation tends to work the best is under capitation and undervalue. And so, it is risky for a health system like mine to invest in innovation when it can potentially disrupt our cash cow of what makes us money today, essentially keeping our hospital at 110% capacity, keeping our ED cranking out patients, and keeping my high cost specialists seeing patients in person and doing surgeries and procedures, right? Digital health kind of throws that whole paradigm upside down. And, as a health system, we have to be thoughtful where we allocate our financial resources, because we still need to make money to invest in the future, which is moving towards capitation. So, I got to be really thoughtful of the solutions that we develop that tackle problems. Is there a short-term business model where they can still bring in maybe revenue or improve quality at a lower cost outcomes that works in a fee for service landscape? But really the goal is setting my health system up to being successful, of taking on more capitated risk, to moving into value. So the areas that we do a lot of our innovation in are service lines like primary care or behavioral health or geriatrics and home care, pediatrics, where these service lines traditionally don't make the health system a lot of money, but we know are going to be the leaders under value, under capitation. And so it's kind of balancing that out. You want to disrupt, but you don't want to totally take away the cash cow, because you need that to feed into getting you ready for the future. And so kind of really thinking through that lens is a lot of what I do.
So let's kind of go do like a high low. High point is something that you took a risk on that turned out to be ultra successful. And then let's, on the contrary to that, let's maybe kind of use an example of you took a risk on something and didn't turn out the way you wanted it to turn out. Can you maybe give us a couple stories in each?
Yeah, yeah. An area that we've invested a lot of resources into is behavioral health. Partly, again, my background started in behavioral health, and so we've built a lot of tech software applications to deliver behavioral health care to underserved patient populations. And we've allocated resources to that where we initially had no funding to support us to build those applications. We just knew it was the right thing to do. And when we've deployed that, that has helped to decompress our psychiatric emergency department. It's allowed us to start to decompress our ambulatory outpatient psychiatry service lines, get the higher acuity patients actually in to see the psychiatrist, and we can then manage the lower acuity stuff using technology. And it's allowed to support our primary care providers who, can be that kind of funnel into the health system where they see a lot of behavioral health but do not feel like they have the support or access to the specialists to deliver that care. So we've given them interventions to support them to do that. That has paid off big dividends for us. An area that we've struggled with, that we've allocated resources to with all good intentions, has been in certain types of machine learning model development. And I'll give you a good example. One of the biggest burdens in healthcare right now that most health organizations are struggling with are clinician burnout. A big part of that burnout is dealing with technology, the electronic health record, and dealing with, your in-basket messages. And I know there's a lot of companies out there trying to work in this space, but we thought, okay, can we develop natural language processing models in the innovation incubator that can help maybe triage those in-basket messages, kind of sort through them and send the messages to the right person. So we're not overwhelming the clinicians, we'll send the right messages to the front end staff, the right messages to the nursing staff. And to be frank, we failed on that, and we failed quickly to it. So, and partly because, the electronic health record has a lot of noise in it, a lot of garbage data, those messages coming in, there's a lot of variability. And we weren't able to develop models that could aggregate those data into the right buckets to kind of sort it out, to triage. And we put a lot of resources into trying to make that work, and we weren't successful. But what we learned, however—
Was that with an internal innovation that you guys built, or was
yeah,
that
that was internal.
external?
That was internal to us building it. Now, where that has been helpful is, we get approached by a lot of startup companies who claim, I've solved this problem. I can optimize in-basket using machine learning. I can optimize the EHR using machine learning.
Are you guys on Epic or Cerner? What's your—
We're an Epic shop.
Okay.
That knowledge base of what we learned by trying to do it internally with, again, our own data scientists in at our university was, what? I am not optimistic that you've solved this problem. And here are the reasons why you've probably not solved this problem. And I don't care, you might have the greatest model in the world that you developed at this other institution, but the likelihood that it's going to be generalizable to my institution is unlikely. And the reason why I know that is because I know my data is a mess. And so that experience has allowed us to not look at flashy lights over here and all these AI companies and say, yes, we need help in this, and sign contracts that we regret later. Other thing, it's really helped us think about where our priorities should be. And one of our major priorities as a health system is setting up an enterprise data warehouse, cleaning our data, looking at where the gaps are in our data, and getting our data in good shape so we can take advantage of all of these great machine learning innovations and these startups that are entering in this space. Until my data is in the right shape, your models probably will not work.
Yeah, it sounds like what it's like is foundationally, if you want to build a 50-story building, you have to have a foundation that's going to be able to sustain that. And it sounds like what's how at least this is what I'm observing in healthcare. There's a lot of really interesting solutions that are out there that really only work if you have a foundation that's suitable for a 50-story building. And I'm an eternal optimist, so I want to see these things work out. My hunch is that you're going to see some buildings that are be coming down, unfortunately, as a result of it. And is that because people are too quick to try to learn the tricks of the trade as opposed to focusing in on foundational things, which is like having clean data? Maybe they just don't necessarily view that as innovation, but to me, innovation is providing value for many and doing it incrementally over time. So if that means taking the time to actually do that, that allows you to really take the next step, maybe some people don't necessarily see it that way. And
Well, let's be frank, the use of artificial intelligence in healthcare is still a very new concept.
right.
I agree with you, Michael. I am an optimist. I do think the future of healthcare is going to be data driven, precision medicine, and machine learning, and technologies like 5G and decreasing latency of data transmission is going to totally disrupt healthcare in a good way. Like I am totally agree with you there. I think that technology moves a lot faster than healthcare, and we've seen it in other
Right.
industries. We have a very broken healthcare system, so we want to get it fixed now. And I think people are just kind of jumping into the deep end too early and saying, well, hey, machine learning totally disrupted retail. Machine learning totally disrupted the airline industry. Oh my gosh, this can fix healthcare, and we need to fix healthcare now. And so I'm going to just jump right on board without really knowing, not spending time in that shallow end of the pool and knowing that, like, hey, well, there are the things we got to work out first before we jump into that deep end. And so, you know, uh, uh, we're going to get there, and we're going to learn, and I think that also gets back to the point of the importance of creating good partnerships with industry, because engineers and the technologists that we have in industry are brilliant, but they don't know healthcare. They haven't been in healthcare, they haven't experienced healthcare. They're not clinicians. And in order for us to figure out, the two of us do have to get together, and we have to have the technologists understand this is the basic core problems that we got to get fixed in healthcare now. And there might not be sexy, but we got to get these fixed so we can use your technology. But we also need the technology folks, because they move so fast, to help kick us in the butt to start
Yeah.
moving and building that foundation so we can leverage the cool stuff that they're developing.
I'm curious, walk me through in your mind when you're deciding to either build something in-house or search externally, what are some of the main factors that you and your team consider when you're thinking through something like that?
Great question. So, as I said, we're an Epic shop. First and foremost, we're going to be Epic first, for good or bad. We've made a
Yeah.
substantial investment into Epic, and Epic is our patient portal and to really have that omni-channel experience, for our patient and our providers, it really has to be in that Epic hyperspace kind of experience. And so our first decision is going looking at Epic, and does Epic have the functionality now to solve this problem? If it does, most likelihood we're going to turn that functionality on, even if it's just good enough. And there may be another solution out in the market that's has a slicker UI UX and is all around a better solution and further along than Epic. If Epic has something that's good enough, that's what we're going to go with. If Epic doesn't have it, we're going to look at Epic's roadmap. Is this functionality on Epic's roadmap? And when is it going to be addressed on Epic's roadmap? We'll partner with Epic and to fully understand that. Now, Epic doesn't have the functionality, it's not on their roadmap, or it's not going to occur on their roadmap fast enough. That's when we'll look external. We're going to look to partnering before building, because we are not, despite having, this integration to the university and having great engineers and software developers, we're not a tech shop. That is not our core business, right?
Yeah.
And I'm going to partner with the best of breed companies and industry out there to bring in solutions to address it. How I find those companies is I talk to my other health system partners. I talk to the other chief digital officers, chief innovation officers, chief technology officers, and other health system peers that I have. And I reach out to them and say, hey, do you have this problem? More likelihood than not, if I have the problem, they have the problem. And say, hey, have you looked to address it yet? How have you addressed it? Who have you partnered with? If they give me a list of this has worked for us, those are the companies I'm going to reach out to first, because my other trusted health system peers recommended it, and that's who I'm going to look to onboarding. The second, if other health systems haven't found that solution, I'm going to go to my VC partners that are out on the West Coast that I trust. And we also have VC partners out here on the East Coast, but there's just so much more happening in the VC world out in California on that side of the country than we have in New York City and Boston in the healthcare space. And we've got partners that, we really look to, and we say, hey, does any of your portfolio companies fill this need? If they do, great. We're going to de-risk your investment by really wrapping our arms around that company and bringing them through our innovation incubator into the health system. If you don't have that portfolio company, you VC fund, can you do a thesis for us? Can you look at the thousands of companies out there that have solutions in this space, and you tell us who is that best company in that space? We'll look to you, VC fund, to make that financial investment in that company. And again, we'll de-risk that financial investment for you by bringing that company into our ecosystem. And then if we can't find that solution, then we build it in-house ourselves. And we don't build to spin out companies. That is not a KPI of our innovation incubator. That is not what drives us of what is the next technology that's going to have a 10x return. We build companies to meet our health system's needs and priorities and to serve our community. And the technologies that we build, we are actually more likely than not to open source our code and give away our technology to the rest of the world than trying to figure out how to make money on it and sell it. And we've done that in a lot of use cases, that we've open sourced our code, and we've actually had third-party companies
give us
come
an
in.
example of when you've done that. Like that's great.
A great example was COVID. COVID hits. And, the first problem we had that first week of COVID was we stood up a COVID telephone hotline that was staffed by our emergency room and urgent care physicians that got overwhelmed by the worried well that thought they had COVID, but they really didn't. And the people who had COVID couldn't get through on that hotline. So the system comes to the innovation incubator and says, I need a solution to triage COVID symptoms. Of course, COVID's new to everybody, so nobody has a solution for this. So we have to build it. We quickly tested what types of solutions would folks consumers engage with the most. Surprisingly, a chatbot was the functionality that folks like the most. And this was well before, Facebook and Carnegie Mellon spun out their chatbots and Microsoft spun out their chatbots. We, in 2 days, spun out a chatbot to
Amazing.
essentially triage symptoms at our call hotline, and we lowered our call volume by 50% in that first week of standing up our triage chatbot. Then the next
50%?
problem, 50%. The next problem that our health system had was having staff exposures to COVID, and we had no way of monitoring our staff's symptoms to COVID, and our employee health record and our university health services EHR, which is separate from Epic, had no mechanism of ingesting that data. So we spun out another version of that chatbot on the front end to essentially check in with our employees and our students every single day. And we built a new electronic health record on the back end to ingest that data and monitor those who were on quarantine or isolation over time. That technology, we had businesses, we had other universities, other health systems around the country begging us for that. They said, we need this. We need this for our employees. We need this for our customers as we start to loosen up social distancing regulations. We need this. And, we said, great, we're just going to give it away to you. We open source that code, we push it up to GitHub. And we had universities, health systems, schools, other employers around the country pull down our code for our chatbot and that kind of health record on the back end to do the monitoring. And we actually, there was a company that took our code, made no really changes to it, and started selling our technology to other companies that needed it. But you know what? Opening source the code was something where we want to help the world, transform the world. We needed to get it out fast. COVID was a big thing, but that opened up doors for us as a university. That got us invited to tables at the Linux Foundation around, open source ecosystems. It got us invited to the X Prize Foundation out of Los Angeles around, sitting at that table around coming up with, new X Prizes to solve the pandemic that hit. And if we didn't open source our code and gave our technology away, we probably wouldn't have been invited to sit at those tables, which then opened up our network even further to innovate. So that's a perfect example of a technology that was needed. It needed to get out quick. And, we said, take it, do what you need with it. And we'll even help you tell you how to pull the code down and use it in your system.
So pause there for a second, because access means a lot of different things to a lot of people. If you're really serious about access, whether it's expanding, ability for people to get in and get care, that's one thing. But if you're serious about expanding access to innovation, like this is it's an incredible example of what it means to actually provide access to those who desire it. Now, mind you, you mentioned that there's going to be some that are purely greed driven, where they get something, they white label it, and then all of a sudden they spin up a company. That's going to happen. But I think what you're doing is you're priming all the people that come into your world that, like, hey, this is our operating system. This is how we are. And naturally, not to get woo-woo, but you're going to attract other people that are like that. So when you get access to roundtables like X Prize and all these other organizations that are pretty phenomenal, just imagine how much more access you can provide as a result of doing what you did. Versus hoarding it. Because I always tell people, like, look, if you're going to hoard something for yourself, actually a great example is something where, like, if you go to the beach, and I grew up on Long Island, so I think you kind of know this, but when you go to like pick up sand at a beach, when you squeeze your hand, that sand is just going out. But if you loosen it up a little bit, you can pick up a lot of sand and keep it. And I think that's the same kind of model that you've just described. So pretty happy.
I love, Michael, that analogy is awesome. I may steal that from you. Yes.
Oh, go ahead. Swipe and deploy. I took it from someone else. So
listen, I'm about impact. I'm about, transforming healthcare. And in order to do that, it's a team sport. Like, it's going to be no individual, no idea. And it's part of why, I work where I work. you got back to, I love to learn more. And I went on to lots of different school, educations and degrees. I'm very, very inquisitive, and academia sets you up there. I do not work at in an academic health system to get rich. Let me tell you that for sure. I work at an academic health system because I get to work with other really creative people who are in it because they want to have an impact. They want to help people and they want to transform healthcare. And that's what excites me, and what makes me really passionate. To me, again, getting rich and making money and, being a CEO of a chatbot company, that isn't what I want to do and what drives me. I want to have a bigger impact on healthcare than that. And to do it is to partner with industry, to partner with other health systems, to partner with foundations like the X Prize or the Linux. Like, that's how we're going to totally transform healthcare and move from volume to value and get to where we know we need to be in the United States.
So look, there's some people that have heard of University of Rochester Medical Center and some of the great work that you're doing. But for those that haven't, what is the best way for folks that are tuning in here, and even just for the future, to the amazing work that you guys are doing? Like, give yourselves a little bit of a plug here before we wrap up.
Yeah, listen, reach out to me on LinkedIn, Michael Hasselberg. We call ourselves the coalition of the willing. So if you have the same ethos and passion that we have, we want to collaborate and work with anybody. So yeah, reach out to me directly. The one thing, we have been told this, people just don't know that. Go Rochester, like, we didn't know you were actually doing all of this stuff. And it's actually been described as another analogy to me from another, like, really well-known health system. And I said to them, I said, what do you mean? You guys are leaders in AI. You're partnered with, the big tech companies to do it. And they said, no, we're very different than you. Like, we've got a really shiny exterior, and we say we've got these partnerships, and we brand ourselves really well and say we're leaders in AI because we're working with this big tech company, but there's nothing under the hood. You guys are the exact opposite. You guys have a lot under the hood. You're actually doing the work, but you don't have the shiny exterior. Nobody knows about you. And, partly, again, that's just who we are. Like, we're not, we are really doers. Like, we're just building it and doing the work and making our community better. And to us, our driver isn't, publishing papers in the, the Journal of Science or Nature, the New England Journal of Medicine. We do that, but that's not our driver. And our driver isn't fancy branding and getting ourselves out there. We just do the work. So yes, we're starting to get ourselves out there, and I appreciate you bringing me on the show so I could, tell your audience about what we do. But yes, please ping me on LinkedIn, and love to tell you more about who we are and how we can work together.
Amazing. So, Dr. Hasselberg, this has been pretty spectacular. If there's one takeaway, one golden nugget that you want the audience to get from this and take action on, that's the most important. What is that one singular thing that you would have them take away with and take action on?
I think it's what I actually just said. Healthcare is a team sport. Innovation's a team sport, and it's all about relationships and partnerships. In order for us to make healthcare better in the United States, we have to work together, and it's going to be a really diverse thought process to really fix the problems that we have in healthcare today. Yeah. Teamwork and, really working with diverse, really thoughtful, brilliant people who have that ethos of, I just want to get this done and have a large impact.
Amazing. So for those of you that are tuning in, if you found this content helpful for you, would you mind sharing it on social media? Would you mind even just commenting, what stood out to you most, or even just liking it, even just comment? I mean, those things matter to us. And I'm grateful when I can get introduced and interact with other folks that want to make a difference, like you, Dr. Hasselberg. It's honestly, it really makes my day when you can interact with people that have that are just excited It's kind of like hooking yourself up to a battery that's a positive battery, as opposed to continue to hook yourself up to negative batteries. Eventually, if you hook up enough to negative batteries, you won't have a battery. So I'm trying to link up with other folks like that, and when we can create a community like that, that is a community of innovators and doers, then I think we're doing some good things. So I'm looking forward to having you come back onto the show at some point in the future and sharing some more cool stories. But for now, farewell. Thank you. Catch up soon.
Thank you, Michael.